we can maybe go ahead and open again on the Q&A list and see what questions we have. So I have a question for all of you is, how does a dentist decide if they are dealing with a sleep disorder or a psychological disorder? Whoever wants to take that question.
So I can take a stab at it, but I would say that the question shouldn't be an either or question, but it would be a both and question, because sometimes you can have comorbid sleep disorders and psychological disorders. So from a psychological standpoint, when it comes to sleep, one of the things that we see most commonly in the clinic is insomnia, right? So this is defined by difficulty initiating sleep, staying asleep, or quality of sleep for at least 3 nights per week for at least 3 months. But there's additional criteria that you have to fulfill in order for us to psychologically, from a psychological standpoint, diagnose insomnia. One of those criteria is that it has to cause significant distress or impairment in function, but the other one is that the primary insomnia cannot be better explained by any other disorder, right? And that's where it gets really tricky, because a lot of times what we see in dental sleep medicine and in orofacial pain clinic is obstructive sleep apnea or some of these other disorders that can be comorbid with insomnia, but that it makes the diagnosis really difficult. So I would say that the best way for a dentist to distinguish these two is to have a really thorough assessment. And what I think that an assessment should include, an assessment of the sleep condition, but also, from a clinical psychology standpoint, the relevant question becomes, is this sleep impairment fully explained by this sleep disorder? So we have someone with primary insomnia. What would happen to sleep if the primary insomnia if the obstructive sleep apnea were treated, right? So if the symptoms are fully explained by OSA, then we wouldn't diagnose necessarily comorbid psychological disorder, but ultimately that becomes kind of a judgment call. So I would say, a thorough assessment is very important, and not to think of it as one or the other, but also is there a possibility that both coexist? The Insomnia Severity Index is a 7-question measure that you can use, and it's publicly available, and that can be indicative. It's not diagnostic, but it can help indicate when there's significant sleep disturbance. So having the patients complete something like that might point you in the right direction, but ultimately, I think it's kind of a judgment call.
I would just editorialize as well on follow up on what Dr. Bajero says. I mean, just look at the base rates in the population. Okay, so a kid comes in who's maybe 11 years old, 8 years old, whatever, with sleep difficulties. If you just look at the base rates in the population, that is not likely to be obstructive sleep apnea. Okay, I mean, and we tend to not think of this, and there's a risk, perhaps by a push from parents, of overdiagnosing a patient and eliminating the hoof steps behind us and looking for a zebra here. And again, there's a bias in that. If we have a hammer, we tend to do a lot of pounding. So that's just my caution.
And I have a question for you. Now, during your presentation, you mentioned a lot about fatigue. Now, if we treat sleep, insomnia, or other sleep disorders with patients, young patients, do you think the fatigue symptoms will be reduced, or we have to look at other comorbidities with these patients?
Thank you for that question. I love that question. It's something that I've been thinking a lot about over the last 7 years. So when you look at the correlation between fatigue and poor sleep, it's about somewhere between the 0.4 to 0.6 range, depending on the specific population. So you have populations like fibromyalgia, where it's characterized by non-restorative sleep, where you improve sleep, but the fatigue is still present, or chronic fatigue syndrome. A few years back, my wife, Dr. Marcia Rojas, who's actually in the audience now, was given the funding by the AAOP to look at what happens to fatigue longitudinally when we treat sleep. What happens to fatigue longitudinally when we treat pain? So she recontacted patients who came into the Orofacial pain clinic 2 to 7 years after their initial appointment and had them provide information on sleep, pain, and fatigue all those years later. And what she found is such cool data, what I think, which is that when you look at, okay, so if you have, a certain number of people, I'd have to look at the data, but over 2 to 7 years, a subset of those people, their pain with appropriate treatment resolved. Their pain got down to 0. So we dichotomized the group into people who had pain relief, total pain relief, versus people who didn't. And what the her longitudinal data showed was that if you can successfully treat pain for fatigue in that group reduces to nearly 0. Whereas in the people who do not have resolution of pain, their fatigue tends to increase over time. So I think it's both. I think treating pain is a really good strategy for treating fatigue. But like I mentioned earlier, I also think that when we look at some of the data, we should also be trying to do something about fatigue, because fatigue in and of itself is impactful, even controlling for depression, even controlling for all these other things. And I think when you treat fatigue, you have really significant reductions in pain-related interference, you have significant reductions in disability, and you have significant improvements in quality of life. So I think both are really important. I think treating fatigue should be, something we should be looking more into. And treating sleep is one mechanism of doing that. But even if you get sleep perfect, you're not always going to totally get rid of the fatigue. That's going to depend on the specific pain diagnosis and on the other medical diagnoses that are comorbid there. So it's tricky. It's a tricky question without, the data don't have super clear answers right now. But that's how it's kind of looking.
Thank you.
Yeah, that's a very, very interesting. We always have in this very complex cases, but right, many factors and many layers that seem to have some interaction among them. So that's really fascinating. So I did have a question for both of you. You mentioned the fresh cuts, and both Dr. Boguero and Dr. Coolidge did, and we talked about what to do with suicidal ideation. But what about if, as a clinician, we find out that we observe the same thing that you mentioned, Dr. Coolidge, that patient might have some fresh cut? What's the best way of addressing that?
I think the best way of addressing that is, I could answer that as a psychologist, but as a for the dental audience, I would say that from a dental standpoint, the best way of addressing that would be to refer patients to a psychologist, because that's not, that's well outside what a dentist would be able to help with unless they have specific training in that. So I think getting people to appropriate psychological care when you notice those things is absolutely the first step. And you can use that link in my talk to find what that care is like in the patient's area. From a psychological standpoint, if I was in private practice and that patient came to me, then we would start with a very thorough assessment of what's leading them to the causing behaviors, what are the antecedents, what are the consequences, what are the predictive factors, and we would do a really thorough evaluation to see what's driving that behavior and how we can go about changing that. But that's not, from a dental or facial pain provider, I think the responsibility is to refer to treatment when you notice that.
Good.
So the
And
question,
I'm going to just add to what Ian had said here. We do train our residents to do a suicide risk assessment, and I think that's that. And I think you probably agree, Ian, on this, that is that's sort of a low-hanging fruit sort of thing. So doing a risk assessment on a patient, asking about imminent plans to harm yourself, and some of the basics that are 3 or 4 questions. Again, that's sort of, that is absolutely within the scope of practice for a dentist. My friend Bob Meyer, who some folks knows, tells this wonderful case where he did have a person who was at imminent risk for herself. He ended up harming herself, and he eloquently talked about calling her significant other, as well as notifying the police. And I have to give Bob Meyer a thumbs up for doing something that's probably well beyond what the typical dentist would do. And I think that's certainly within your scope. So I agree with Dr. Bergero on that referral and do a risk assessment.
Dr. Kolish, like with your case with the patient who had the cut on her arm, how would you address the issue with the parents and with the patient if she's, by herself?
I think that the issue of being candid is extraordinarily important. And it's usually our anxiety that stops us from asking the question rather than or conferring with the family than the patient or their family's anxiety. So once we get past our anxiety, the issue is with this particular patient is putting out front the patient has been involved in self-harm, and are they currently in therapy? Is there a person that they contact on a regular basis? I mentioned a risk assessment, and the idea of referring a patient to a clinician, or even picking up the phone and making a call to a mental health provider in some cases to reinforce follow-up is not unreasonable. Again, there's often a phobia for picking up a call and making a phone call. There's nothing wrong with the dentist on a regular basis doing a crosstalk with a treating doc. And if this is a family or a patient I think picking up the telephone and sort of reinforcing that follow-up is a good idea. So that's actually what we did in this patient from what I recall years ago.
Thank you. That's really useful information for us as dentists. So we do have a few questions for you, Dr. Perez, in regards to the cases that you had presented. So particularly in the first patient, the question that the audience is asking is, was she able to breathe through her nose, and how did you deal with the tongue thrust swallow?
Yes, I saw that. And I want to, if you guys want, we can put this picture up again. Let me see if I can share screen one more time. So we can talk about this. That's a great question, by the way. And let's see, share screen. There we go. Oh, I'm disabled because I got knocked out, I guess, and I'd have to go back in. So if you could put me again as co-host, that would be good. So while we're doing that,
I think you need to do that.
Okay. Let's see. Yeah. In any case, so yes, she was able to breathe her nose, and we do evaluate that prior to starting treatment. So yes, that was one of the things that we looked at. And the tongue thrust, that's an important one, and it's a difficult one because when her occlusion was normal, she had an anterior stop in which, to put the tongue so that she could have a normal swallow. Once you lose that, the tongue immediately goes to that open space and there's a tongue thrust. So it was one of her problems. However, kids are quite malleable. And let's see here, maybe I can share screen again and show you guys. That's okay. So once she was able to eliminate the appliance that she was using, her bite changed very rapidly. And so the idea that she had an open bite sort of changed relatively quickly. And so the tongue thrust wasn't a big issue. at that
Okay,
point.
now you are a
So,
co-host. You can share the screen.
okay. All right, good. Let's see here. Okay. So this is the picture of Gabi. This is the picture of, this is the picture of the patient. And as you guys can see, the anterior open bite that she had at the beginning was minimal. And then after we stopped using the appliance, the bite seemed to close relatively quickly. So we didn't really have that issue after that. And then the tongue or the nose breathing was, she had patent nasal breathing. So yeah, those are the two questions that you guys had. And I just wanted to show you a picture of what she looked like, and that sincerely, the tongue goes to that front to close that space relatively quickly. But without the appliance, it changed. So
good, yeah, and I agree that answers also another question that we had in our chat about, how long would you recommend waiting for the patient to be pain-free before addressing the occlusion? Obviously, in this case, it seems that it naturally corrected once you remove the appliance, but in a case that it might not have got corrected, how long would you wait before recommending any reversible occlusal treatment?
So ideally, we'd want the patient to be pain-free. That's the main objective. And that sometimes is hard because it doesn't happen from one day to the next. In her case, we had her on amitriptyline for 2 months before we started decreasing the dose. So I would say in her case, it was about 3 months before we even initiated the orthodontic treatment. And that's a difficult one because all these kids and the parents are looking for her to have an objective change to her bite, of course, because that's what you can see. And you can't really see pain. But, pain is something that moves a lot more than straight teeth, right? So we have to have them pain-free before starting, as pain-free as we can. And this little one had episodes of pain throughout the day, which were associated to posture and associated to stress. And those factors were analyzed by the behavioral team. And they did so well. They did their job so well that a smart kid like her was able to take that information, put it into action, and she just felt better right away. So, after she was significantly better, so 2 months after her treatment, I would say she probably started back with the orthodontist the 3rd month after we saw her.
And precisely talking a little bit more, expanding a little bit more on what the behavioral team was able to offer her, would you mind revisiting the PSR slide on your case?
Yes.
One? And maybe, you guys can cover, Dr. Boguero, Dr. Perez, a little bit what that PSR, consultation or evaluation was about.
Sure. I'm going to, again, share my screen. And I certainly think that Dr. Boguero can explain this much better than I can. For me, this was almost like a screenshot that I took of the consultation that day. So I'll show you guys what it looks like here. Let's put it on. There we go. So this, I guess at the beginning, sort of information on PSR, and they introduced it as noted there. And Dr. Boguero, please go ahead and take over, because this is what you guys do on a daily basis.
Sure. So PSR is an intervention that we use in the clinic. It stands for physical self-regulation. It's a 3-session protocol. And we use it primarily for patients who have a muscle diagnosis. So masticatory myofascial pain, masticatory myalgia, centrally mediated myalgia, any muscle diagnosis. And what we do in the intervention is my team first does a thorough psychological evaluation. But then once we get started on the intervention, what we do is we teach patients a set of skills that we think is going to change their muscle physiology in a way that makes pain healing more likely to happen. So we talk about clenching and clenching awareness, and we teach patients strategies for monitoring and reducing their clenching behavior and their other parafunctional habits. We also review diaphragmatic breathing and postural relaxation as a way to increase parasympathetic nervous system activity and reduce sympathetic nervous system activity. And we teach several other exercises of the head and the neck that we think help reduce muscle tension systemically and trigeminal function activity specifically. So it's a protocol that we've developed for that purpose. Dr. Carlson, who was here before me, started implementing the protocol in 2001, and he actually published a randomized clinical trial of PSR in the clinic, which you can Google if you look up Carlson Physical Self-Regulation 2001. Yeah, it's basically a brief behavioral intervention that we think helps reduce muscle activity and muscle function in a way that makes pain healing more likely, in a nutshell.
Thank you. So we do have another question in regards to the cases that you had presented, Dr. Perez. And the question relates if a history was taken regarding familial headaches, and if it was considered an early onset of pediatric migraines.
Okay, another great question. We took a history in both cases because both had a significant headache component to their pain. If I am not mistaken, neither of them had a familiar headache that would lead to the diagnosis of a migraine in the future. However, that's quite prevalent in our population. But these two kids specifically, I don't think that they had that component.
So we do have another question in regards to the second case and the headache component. So it did mention that the headache was on the frontal side every day until going to bed?
Yes.
Okay. And the question and follow-up question on this one is, what were the causes and the result of these headaches with the follow-up in this case? What was the diagnosis, and what was the outcome on the second case?
Okay, so I'm looking at the slides just to make sure. This was some time ago. So this kid, and I'm sure it happens to a lot of you guys, once they feel better, they don't come back. So this child, we saw her the first time with her specific headache. We sent her to our behavioral team, and she had her physical self-regulation training. And the second session with them, she was a 0 out of 10, and we did not see her back after that. So we don't have a follow-up from the Orofacial pain clinic. However, the behavioral team is what has been looking at her continuously. So yeah, we don't have a second visit for her. We just have the first visit and then the PSR visits for her.
Another, and this is probably more on the administrative side of things, but what code could be used for the PSR sessions in regards to insurance reimbursements?
So in the clinic, my team uses 96158 and 96159, which is behavioral health interventions. So those are the two codes that we use. I'm not sure how applicable those would be for dental providers, but that's what my team uses in the clinic.
Yeah, and that's correct. I would add to that, those are psychological services.
And I see the other question in terms of substance abuse patients, if there's any modification in PSR. Not necessarily. The only modification is that if you do have a substance abusing patient, just to make sure that they're, getting the appropriate treatment for that elsewhere. Or at least, yeah, hopefully they would be in treatment for that. But in terms of would we modify the exercises in any predictable way? Not necessarily, not in and of itself, just because of a substance abuse diagnosis. I think the big question there is, are they getting the kind of help that they need? And being sure that you're talking to the patient about that would be really important. So that would be how I would modify my approach there.
Before we conclude, I have a question for both Dr. Boguero and college. If we have 4 elements, we have a child or childhood or child, let's say child, a parents, and chronic pain and mental illness. Where was the interaction between the 4 of them? I'm sure from your experience, both of you, is it really there is more patients with mental illness has more chronic pain, or more parents with mental illness and chronic pain have more children with these kind of elements? I'm not sure. It's a big question, but briefly, a couple of minutes from each of you.
I mean, that's a really complicated and broad question. Certainly there's higher rates of chronic pain within certain mental health diagnoses. So things like major depressive disorder can be a risk factor, things like bipolar disorder, so there's definitely higher pain within certain mental health diagnoses. Now about the familial piece, yeah, I think it all goes together to some extent. I mean, I don't think it's right to think of those four things as four distinct things. I think that they're all part of one comprehensive picture. So I think that they all influence each other in really nuanced and complicated ways. But I don't think it'd be right for me to say I see this relationship specifically, because it would just be a lot more complicated than that. I think they all go together in really powerful and complicated, nuanced ways.
Dr.
Yeah,
Kolesh?
I'm going to echo what Dr. Bajero says. So these are correlated, obviously, and there's a relationship between them, as he notes. But it actually is sort of an interesting thing, because it actually gives you a hook. If in one of those groups you see lots of pathology, it gives you sort of a nudge to assess in the other category what's going on. So if there are family issues going on with a lot of pathology, assess the patient and vice versa. So anyway, it just flags me to encourage people to assess more and look more and get to know the patient.
Thank you very much. I really like to thank you all for great webinar presentations and discussions, cases also. I'd like to add that the American Academy of Orofacial Pain has in line 3 more presentations, one in February, March, and April. This will be directed toward new beginners, dentists who have interest in orofacial pain practice. So stay tuned. Dr. Hay, do you have to add anything?
No, I don't. Thank you very much, everybody, for being with us and joining us. And thank you to our wonderful 3 panelists for your insightful comments. Thank you.
Have a wonderful weekend, everyone. Thank you.